Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. At any time during today's presentation, you may submit your questions electronically using the chat window located to the right of the slideshow presentation. It is now my pleasure to introduce today's first presenter, Ms. Brigetta Kraft.
Hey, hello everyone, and welcome to the TeamSTEPPS for Office-Based Care online webinar. Today, we're going to be exploring and discussing the MetroHealth story and their journey in taking TeamSTEPPS beyond the hospital to the primary care settings. This is Brigetta Kraft, your host, and I'm also one of the course directors and facilitators for the TeamSTEPPS for Office-Based Care online course. We're glad you were able to join us today. And for those of you who are already enrolled in a cohort, this webinar is part of a library to support your work in the TeamSTEPPS for Office-Based Care online course. This webinar and the others are part of the curriculum and will be useful for you in obtaining your Master Trainer certificate upon successful completion of the course. And as a reminder, the last day to complete all work in cohort 11, which is the final online cohort, is December 12th. After December 16th, AHRQ will no longer be supporting the TeamSTEPPS learning management system, so it's important that all CE certificates be saved and printed by December 16th. The Office-Based Care individual modules will continue to be available until December 12th. For those of you who are not enrolled in a cohort, this webinar will be added to the online TeamSTEPPS webinar library as a resource for you. I'd like to extend particular thanks to the Agency for Healthcare Research and Quality, which is part of the Department of Health and Human Services, for funding the TeamSTEPPS for Office-Based Care online work. We really appreciate the work they've done in moving the ball forward in the patient safety and quality improvement field. Now, a few rules of engagement before we kick things off. You can listen to the audio on this webinar in two different ways. Through your computer speakers, or you can do so through the phone. And if you do this, meaning if you're listening through the phone, remember to please mute your computer speakers. If you have any questions during the presentation, please feel free to chat them into the chat area located on the right-hand side of your screen at any time. We'll do a Q&A at the end of the presentation. If your questions are more logistical, we'll answer them right away. But again, if it's more discussion-based, we'll take care of that at the end of the presentation. This webinar will be recorded and archived. In addition, you can download the slides via the Files pod. And finally, for those of you attending live, please keep an eye out for the evaluation, which will be emailed to you after the presentation. Now, it is now my pleasure to hand off to the MetroHealth team.
Hello, my name is Maria Podmore. I am Director of Nursing for part of our ambulatory services.
Hi, this is Katie Carney. I am the Associate Chief Nursing Officer for the Ambulatory Operations here at the MetroHealth System.
Hello, I'm Dr. Bob Smith, and I'm Director of the Medical Staff Assistance Programs and also Director of TeamSTEPPS. On behalf of the MetroHealth System, I'd like to thank AHRQ for inviting us today to share our journey in implementing TeamSTEPPS with our ambulatory network. And I'm really grateful for Maria and Katie to be here to tell the story because they really were the champions to make this occur. To sort of set the stage, I want to give a little overview of who MetroHealth is. So MetroHealth is in Cleveland, Ohio, situated right on Lake Erie. We've been serving Cuyahoga County since 1837, so that's a little over 180 years. We're a level 1 trauma unit. We have a burn center, a level 3 NICU. We're the one of the academic medical centers for Case Western Reserve University School of Medicine, and we're also a magnet organization. We're probably what you would call a moderate-sized organization. We have about $1 billion in operating revenue and over 1 million ambulatory visits, which is going to be our primary focus today. As you can see, we have a very busy emergency department. We have about 7,500 employees. We've been expanding over the last several years, and that has been a major part of how to get TeamSTEPPS to all the various locations. So we now have 23 health centers, as well as 9 pharmacies, 5 MetroHealth Express Care, 4 Discount Drug Mart clinics, 3 community EDs, and now recently we've opened 2 micro-hospitals. So the focus has been not just to have TeamSTEPPS on the main campus, but to spread it throughout our organization. Historically, we began with TeamSTEPPS in 2013. At that point, I was identified as the champion for the organization, and we established an interdisciplinary change team. That team, working together with our leadership, decided that we would use a train-the-trainer model for implementation, that we would implement system-wide, meaning we would train both clinical and non-clinical staff so that everyone would have a common language and would work together to provide the best care for our patients and to develop a culture of safety. We developed our training course, trained our master trainers, and then we began moving forward. We started initially with our inpatient units, those that were most interested, ED, OR and PACU, all of the ICUs, and then gradually have moved throughout the system. At this point, we've trained about 95% of our organization. One of the big challenges was our ambulatory network, and I'll let Katie and Maria tell you about that.
All right, thank you, Bob. As Bob said, MetroHealth is located near West Side, very close to Lake Erie. So we have 3 regions off of the main campus, our east, west, and south areas. In 2016, we had a really significant integration with a large primary care network where we added a number of facilities and over 200 staff, which included providers, their facilities, and all of their equipment. So literally, within a couple months, our ambulatory network grew significantly. With this growth, we needed to build new teams, and so we collaborated together on best practices that we found in both organizations, and TeamSTEPPS helped us do that. With the implementation of TeamSTEPPS across ambulatory, we moved forward with the train-the-trainer model, as was mentioned previously. It was really important for us to provide out-of-staff time for instructors across the system, which was not so easy. We also needed to engage our providers because we felt that it was very important that we had an interdisciplinary team of trainers. In some cases, this did affect templates. We had to do some closing of templates so that we could afford people the time to participate. But as a group, we worked really hard to provide alternative times for training. And so there were numerous sessions that happened in the evenings and on our Saturdays. So I will now turn it over to Maria.
Thank you, Katie. Ambulatory leadership started to hear about TeamSTEPPS successes in the hospital. I'd like to share some background as it relates to this pitfall we mentioned on the slide. We were in the process of moving a clinic to a new location and a new building. This group had endured some relationship and team issues, resulting in dissatisfaction in many areas. They had already participated in a couple of team building programs without improvements or changes in behavior. The move was going to change their culture. The old location was a small building with a primary care focus and a private practice model. Communication was in close proximity. They had older technology, veteran staff, and pre-existing processes of their own. The new location was going to be the new flagship for the ambulatory services, which would result in increased attention, multiple floors, added services, multi-specialty, communication technology, increased number of staff, and use of system standardized processes. It was not going to be business as usual. The leadership for the site believed TeamSTEPPS could be a quick fix. but the timeline was too short to use the train-the-trainer approach. We had to resort to utilizing our master trainers from other settings in a single-day course for all of the staff. We did attempt to train a few of the staff members to work with the master trainers, but it was not enough time to get them fully engaged. The process felt like an assembly line and just another flavor of the month to the staff. It was time to go back to the drawing board. Lesson learned how not to roll this out to the ambulatory sites. We created an implementation process comprised of 3 stages. Stage 1, planning. Here we identified instructors. We would conduct a survey to the site staff and develop a tailored curriculum to departmental needs. It is key to having leadership engagement so everyone will follow the leader, so to speak. Stage 2 is training. This is where TeamSTEPPS is shared with a department or location, and it's very important to obtain engagement at this time. Stage 3, sustainment. The question was, how do we prevent change fatigue and maintain engagement? We created TeamSTEPPS Action Council, fondly referred to as a TAC. It is here the team can implement solutions using TeamSTEPPS concepts. So getting a little more into detail. 2 of us attended one of the first AHRQ primary care TeamSTEPPS master trainer classes to assist with developing an ambulatory focus on future training. Through our train the trainer model, we had 24 instructors identified from the ambulatory setting to help design the curriculum. This team was comprised of physicians, managers, nurses, medical assistants, and registrars, all from the various locations, creating a universal ambulatory design team. This was accomplished with weekly meetings. We divided the content into 4 main topics: leadership, mutual support, situational monitoring, and communication. Each person was allowed to select a topic of interest, but then with some gentle manipulation, we ensured groups were diverse in positions, personalities, and locations in an effort to prevent the silo effect. The development of the program took longer than expected, approximately 6 months, but the pressure was on to get this rolled out. First thought was to close provider sessions, as Katie mentioned earlier, to free up the staff and train as a team or location. But with so many locations and clinics, that was going to be a problem on many levels. There was too many locations, too many sessions that could be closed, too many travelers working in multiple locations, which put them at risk of getting lost in the shuffle. And then it could be a huge impact on staffing and revenue. We also needed to allow for variability in meeting the different needs. So we provided the basics that could be adapted or specialized. One of our larger clinics on our main campus, internal medicine, decided it would be least impactful to their business to provide training 1 topic at a time per month. Over a 4-month period, they provided 1-hour learning sessions, a different topic each month. But for our off-site satellites, we needed to be a little more creative. To get creative, we needed to acknowledge the barriers and think of solutions. For too many locations, we decided on an integrated approach. This was beneficial since there were many travelers working with different teams. This also allowed for self-selection of a training session and a location. We identified premium conference rooms at our larger sites, making sure to include one on each side of town. There was minimal impact on staffing because managers could send employees when it worked best for their clinic. The revenue impact was minimal because we did not have to close sessions as many as we thought. But some providers were given the option to close a session but add to their other sessions in an effort to maintain their volumes. To capture engagement of staff, it needed to be fun and interactive. It was important to make it memorable and give the ability for them to connect to the content. Also, having homegrown instructors created more acceptance and was an added plus. Now that we had the basics created and barriers identified with reasonable solutions, we needed a framework to roll it out. To determine the number of sessions needed, we took the total number of staff to be trained and divided it by 20, which we came up with to be the maximum number of staff to be in a class to be most effective. In the end, we found that 10 to 15 was even better. Locations were identified on each side of town. Because instructors were from the different locations, we needed a tool to allow them to sign up on specific dates and times on their own. We found an online tool that worked out well for scheduling them. We used our internal learning management system for employees to sign up for these classes. To ensure variation in skill set attendance, providers had a separate calendar to sign up on. As departments or locations struggled with how to implement, we allowed for creative scheduling options such as offering evening and weekend sessions. Believe it or not, a couple sites picked a weekend session. As needed, we called on our TeamSTEPPS champion, Dr. Smith, to step in and provide additional motivation. Throughout this whole process, we utilized TeamSTEPPS tools to resolve conflict and overcome hurdles. As we developed the program, we needed to make sure we can capture and sustain engagement of the participants. It could not be just another program or flavor of the month. We did this by adding videos that simplified the concepts and were entertaining to create laughter. Many of these videos were animations found on YouTube, commercials, and mini presentations or skits. In addition, our group took the opportunity to create their own video demonstrating first an undesirable approach, then a desirable approach using the TeamSTEPPS tools. This really made it relatable by including people they knew and a familiar environment. As we all know, an audience's attention span only goes so far if sitting for a long time. So we needed to get them out of their seats. We found an exercise utilizing tennis balls to simulate the 4 principles. The balls represented patients. The group represented employees of a new clinic that needed to create a new workflow. So in an effort to keep this simple, what we did is everyone would stand in a circle, one big circle, and the ball had to be thrown to each person one time until everyone has had it and it returned back to the original person. Everyone had to remember who they threw it to. This became the new workflow. An exercise was conducted after each principle was taught, building on the last one. So by the 4th time they did this exercise with the tennis balls, they had anywhere up to 13 balls going at one time. The key was if things got out of control to use their TeamSTEPPS tools. Frequently someone would call for a huddle so they could brief and figure out how to do this better. As the momentum was going, facilitators would pull people out of the circle to represent events in a clinic, such as employee goes home sick or goes to lunch, or an employee gets pulled for an urgent situation. The group had to adjust accordingly, and it was fun. An email blast was sent to the various levels of leadership in ambulatory and management providing instruction and expectations. So this went out to all the medical leads, the regional directors, the directors of nursing, and operational managers, nurse managers, anyone in a leadership role in ambulatory. It ended up being a slow process once we had everything in place. So we needed to cancel our first 8 sessions due to lack of understanding and expectations. These sessions were 4 hours each, and we usually held 2 in a day, twice a week. Dr. Smith had to continuously engage senior leadership to allow participation. We recruited a small group to attend the first class. It was a big hit. As the word got out, classes started to fill. We did end up canceling a few more sessions so we could funnel people to fill the other classes. And then we added additional classes as needed. The next hurdle that presented itself was getting instructors for each session. This ended up being in addition to their day job. So the clinics were having difficulty sparing the time from staffing or getting them out of clinic to instruct. So again, in the spirit of being creative, we developed instructors from our ambulatory float pool. This is basically an internal staffing agency. They were familiar with the different locations and the cultures, which made it very beneficial while instructing. To make it easier, we created a trainer kit that had all the tools, so it was a grab and go. This included a binder with all the PowerPoint slides and speaking notes, the bag of balls, candy, because we need to feed them, sign-in sheets and feedback forms, and any of the exercise tools.
The key. 219.
Sorry for the pause. So over the less than a 2-year period, we provided over 50 sessions that were completed. At least 633 participants, there were at least 633 participants, including all skill sets. This went over at least 27 different departments and locations. And currently, on occasion, a department or site will ask for a session and we take it on the road. It continues to be an ongoing process, and now it is desirable. The best part of all this was the feedback, as the feedback started coming in. Despite the pushback, lack of engagement, and difficulty getting to a class, the overall perception was very positive. I'd have to say at least 90% or more rated it as very satisfying. There were many comments of individuals admitting they had a lack of interest in the beginning, but ended up loving it and making statements that it was the best class they've ever attended. The most common favorite tool was the ability to cuss. Acknowledgement of success was very prevalent in the comments. And on a side note, staff from the original site or the flagship site then attended these sessions as well. So as we continue to talk about stage 3, I will hand over the presentation to Katie.
So how did we continue the excitement? The implementation of the Team Action Councils, or TACs, were really important. We needed to engage all the stakeholder groups in the sites and in the clinics. So our TACs needed to consist of not only the clinical staff, but providers, PSRs, which are our front desk registration staff, environmental services, facilities, maintenance, mental health police. We have a number of sites that also have radiology, pathology, and pharmacy. So the ideal is that you have representation from each of these stakeholder groups. So the goals of these councils is to improve our patient safety and customer service, improve patient customer satisfaction or patient experience, improve our employee engagement, and improve the processes and increase efficiencies, so Lean Six Sigma philosophies. So the structure of our TACs had 2 co-chairs, and the co-chairs need to be frontline staff. We don't want managers or leaders moving this group forward. It really needs to be the people that are doing the work every day. And the goal, as I said before, was to have representation of all of the stakeholder groups. The ideal situation is to have inclusion of a patient or family advisor. We've been doing a lot of that with our patient experience team, so they should, of course, be included in our TACs. And so we looked to providers and staff to give us a suggestion of who might be the right folks to participate in this group. The team also needed to have an administrator, but it needed to be somebody who was selected by the team. We didn't want someone assigned. We wanted somebody who was highly engaged, but this individual needed to be somebody that would be an advisor, but also an advocate and remove barriers for this team. So I thought it was really interesting because they picked people that, I was really surprised that they picked people that didn't know the site at all, but they really saw that person as someone who could really advocate for them. So I thought it was terrific, and I think that the leaders that participated really got a lot out of it as well. We also had a TeamSTEPPS master trainer that was part of that group. So I'm going to give you a couple examples of what some of our teams did. So we have one of our largest sites, which was a site that became a part of MetroHealth in 2016, and they came together as a group. It was really impressive last December, and they had a lot of participation. Now, this is a site that has a micro-hospital, has an emergency department, has 13 clinics within the building, has a pharmacy, pathology, radiology, and MetroHealth police on site, EVS, facilities, and almost every group showed up. It was really encouraging. So what they've done is they've talked a lot about what is better for their patients at the building, what is better for patient flow, how do we better take care of our patients, how do we make our building look better. And one of the things that they came up with is, despite having patient parking, they noticed that a lot of the employee parking was actually closer to the building than the visitor parking was. And this is a site that had a very elderly population, folks with a lot of physical needs, and they thought as a group that they really should shuffle the way the parking is done. Now, it might sound simple, but it was highly controversial in the site. People were very, the team was very engaged around it, but they found that some folks really didn't care where everybody parked. They wanted to have the close parking spot. But as a team, they reorganized the parking. They created a parking badge that you would have that indicated where you would be, and they really had to be the group that sold it to the staff. And they've done that. And so now they've moved things around that our patients have the closer parking, which is really the right thing to do. Our main campus clinics, we have a number of surgical clinics that work together, and their TAC is inclusive of the orthopedic department, the ENT department, and the surgery clinics. And so they had noticed that they've had some concerning events with patients, and some of the clinics are quite large where folks were maybe in a back hallway, and they felt that they were a little bit vulnerable. And that team decided as a group that they were going to relocate panic buttons that they had in the department and have them in key areas where they felt a little bit more isolated, depending on how the clinic was flowing. So, both of these examples really, the people who do the work and are living, what is going on day to day at their site or their clinic really know what it takes to change and make it better for the patient and for the staff. And so I thought these were both terrific examples. So I'm going to turn the next steps in sustaining it over to Bob.
So the TeamSTEPPS Action Councils were really the move from having a training program where you educate people and give them skills to moving to where they actually use those skills on a regular basis. And we found that for sustainability, the TeamSTEPPS Action Councils gave our staff the opportunity to use those skills, because now they're going to work on quality projects, it's interdisciplinary, and they're going to be meeting on a monthly basis. Well, then the thing became is, as they grew, we now have 15 TeamSTEPPS Action Councils or TACs, and we look to add another 4 or 5 over the coming months. How are we going to keep track of what's going on, and how do we keep them motivated? Well, the first thing is we have a master trainer on each of them who sort of is there to support them, provide them encouragement, and to help them when they run into barriers, as well as their administrator. So that's to keep it going. Then we wanted to make sure, how do we monitor what's going on? Well, we developed a process where once a month, each of the TACs, the chair or one of their representatives, calls in and gives us basically an update. They tell us what projects they're working on, what progress they've made since last month, and if they have any barriers, what are those barriers, and if there's ways that we can support them, we do that. In addition, that allows the various TACs to share across one another. So if one TAC is working on a project and they have a really good idea, another clinic may have a similar issue, they may borrow from that idea. Or it may be something that goes across clinics and they may work together on that project. So it's been really interesting watching how the TACs have evolved and how the communication keeps getting better and better in terms of sharing ideas and working together in a collaborative way. So this slide shows we have the monthly huddle or call out where people can either come in person or call in. They provide their update, and it gives us the opportunity to make sure that everyone is still meeting regularly, having good attendance, staying focused on the sort of shared mental model of what we're trying to accomplish, and that they're using the TeamSTEPPS tools. We've also found recently that it helps us identify when we need to do redosing to train areas that maybe it's been a lot of turnover or changes in staffing where we may want to redose them with TeamSTEPPS so that they remember all the tools and are using them. So this is sort of an interesting little checklist that we put together based on TeamSTEPPS. So when we do the monthly call-in, individuals know what it is that we're looking for them to share. They just walk through, reminding them to mute their phone and to tell us, you know, when they last met, who's present, what projects they're working on, and their progress. And this is just an example of some of the TACs we have. Now, I don't know if I emphasized before, it's both clinical and non-clinical. And so what you'll notice is we have certainly all the clinical areas listed here, but you'll also notice that number 7 is information services. So they've actually become one of our major areas that support and use TeamSTEPPS tools on a regular basis. They have a TAC. They even have a monthly newsletter that they put together regarding TeamSTEPPS. So again, all of our TACs are spread throughout the organization, and we're formed based upon how people work together. So the TAC is, we don't tell them who should participate in their TAC. We let them decide. So on an inpatient side, the PICU, SICU, and burn unit decided that they would come together. Labor and delivery, NICU, and postpartum decided that they would come together. As we're looking at ambulatory, we may end up with TACs at each of the major sites, but then some of the smaller sites may come together and do regional TACs. But again, it's going to be what works for them, what makes sense in terms of bringing a team together that can work in a cohesive way.
Right, so as Bob highlighted that the projects were reported monthly, but the other thing that we wanted to do is we wanted to celebrate the work that they did. And so we put that out there on our intranet site, and we highlighted them at a number of seminars and conferences. we had to look across the system and see who is ready for a TAC, because it's really about the environment of your site being ripe for it. And if you had some sites that had troubles or had a lot of issues, a lot of discontent, they might not be ready for the TAC, and I think some folks felt like the TAC was going to be the answer to all of those things. So what we did is we looked as a leadership team, and our leadership team, we have an ambulatory triad and 3 directors of nursing that are part of that, working with all of our site and clinic leaders and talk to them about what they thought makes sense. A number of site leaders have numerous sites, and is it the right thing to do to have those sites together as a group, or do you partner them with another bigger site in the region? And we wanted them to feel like they still had some individuality and that their ideas were heard. So we made a goal this year that we would have 3 new sites take on implementation of a TAC. And one of them was our Parma site, which I shared the parking initiative. They were ready. They were a highly engaged site. They wanted to do things to move things forward. Another site was a site that was a little bit smaller, but they had come together. We had combined 2 sites the previous year. We had done a lot of team building with them, so things were certainly not perfect, but we decided we would move them forward, and they are just at the beginning stages of implementing their TAC. And then we have a site that has had a lot of problems this year, and we've done a lot of rebuilding at the site, and they're feeling like things are going in a really positive direction, and they would like to have their first meeting by the end of the year. So certainly folks were in different phases. As I said, at our main campus, we did put some of the surgical clinics together, but internal medicine was one of our first to roll out, and they decided that they wanted to remain independent. So I think it's important for you to have the feel of your clinics when you're looking at how you want to roll this out. And once we know that these 3 TACs are really rolling along quite smoothly, we're going to look to engaging other teams to move that forward in 2019. So our next steps are really about how do we keep this momentum going and continue the good work that each of the sites are doing and using the TeamSTEPPS principles.
Okay, well, thank you. Well, we have a lot of questions for you. We'll start off with the key one that I always hear is, how did you get physicians engaged?
So Maria would come to me and say, gee, we're getting ready to do this clinic or this satellite, and we're just not getting any interest from the physicians because they're feeling overwhelmed. So what initially I would always do is go to the chairperson, talk to the chair, and then we have what are called service lines, and I would go with the service line directors and chat with them and say, how can we arrange for our physicians to participate? Because if they're going to get penalized by taking time away from their template, they're not going to be wanting to do that. And so the chairpersons were very, very supportive. The service lines were very supportive. Once I had their assurance that the physicians would be given time to participate, then I would go to the physicians and explain the whole process. One of the things that becomes very important in presenting TeamSTEPPS is that you help people understand it's not a new initiative. This is not additional work to be done on top of what they're already doing. I always reuse the analogy, let's say that you're going to build a shed in your backyard, and you've got some tools, you're going to build this shed, and you've got a hammer, and you've got a screwdriver, and you've got a rusty saw, and all these tools will work, and you'll be able to build the shed. But then your neighbor comes over and he goes, you know what, I got all brand new tools, and I think if you use these tools, you'll be able to build your shed more quickly, and it may even be a better shed. That's what TeamSTEPPS does. TeamSTEPPS provides tools and strategies to improve what we're already doing. We're already doing quality projects. We're already doing patient experience, Lean Six Sigma. We're looking at how to engage our employees. Those are not new initiatives. Those are things we're already doing. If we can take TeamSTEPPS and integrate it with all those processes, we're going to make it more efficient and more effective. When the physicians heard that, they became more receptive. Because again, they're thinking it's another sort of flavor of the month training program. They'll have to go through it, and there won't be anything that will come from it. There won't be any real benefit. And the fact that we're 5.5 years after the first implementation of TeamSTEPPS, we're still talking about it, we're still using it, and we have 15 TeamSTEPPS Action Councils. I think that shows that, you know, it's here to stay. The other thing is, Maria was sharing the satisfaction reports from the participants. Physicians would say over and over again, boy, you know, I really was dreading this, but I'm so glad I did this. This is probably one of the best trainings I've gone through. So that ended up being positive sort of PR for us. And again, as the word got around, physicians were less reluctant.
Awesome. Thanks. Yes, it's letting them know we're not adding more to their plate that's already boiling over, right?
Oh my gosh, yes.
So the other, yeah, I know, it's crazy. The other question was, were your employees, the providers and other staff, paid for their attendance at the evening and weekend sessions? And then for those non-exempt employees, were they paid at an overtime rate? How did that work?
This is Maria. Yes, all the employees were paid for their participation, even if it put them into overtime. It's part of kind of the legal aspect. We have to pay them for anything that's required.
But I think we were creative. Mm-hmm. So I think if, you know, doing the 1-hour sessions made better sense for a clinic, that's what we did. If we wanted to maybe just close the template a little early, not necessarily block out a session, but do an evening dinner session, you know, that's what we did. And then on the Saturdays, and we do this when we manage our overtime weekly anyways, is if there are opportunities that people can leave a little earlier on another session because we know they're going to go into overtime because we have an evening or a Saturday session, we would do that. And the managers are very diligent in managing the time that their staff are spending in clinic and ensuring time doesn't go into overtime. But yes, it was a financial commitment to do this because we did shave some templates down a little bit, and we did pay people to be there for extra time above their budgeted hours.
Great, thanks. Yeah, we've had a lot of questions come in about the logistics of the templates and, you know, how you manage when patient access is just a concern these days. So were the in-services or those 1-hour sessions, were they at times when there were no patients there normally, or did you, I hate to say the word, cancel some patient appointments or just not have them available for booking during those times?
Yeah, so Bagito, the way that we did that, we would allow, so part of it was people were wondering, you know, why didn't we do the trainings with the team at one location? If we took one location and trained everyone there, we would have to shut down the clinic. That would be a little bit too much of a cost to the organization. So what we did is we picked an east or west side location to do the training and then allowed each clinic to send a couple people. That would make up a class. So that way no one clinic would be so short-staffed that they would have to stop patient care or interfere with their ability to provide services. They would be able to cover. So that way you could create a class of 12 to 15 with people coming from multiple sites, offer that class, then the next time that people would come from would be different people coming from those sites, and you would rotate them until you had everyone that went through the training.
And for some of the providers, they were able to consolidate their administrative time so they wouldn't have to close any templates.
It's all about thinking out of the box, isn't it?
Yep.
You know,
Exactly.
Birgitta, that's an important point. One of the things that Maria and I would do when we would meet with groups is we would ask them, what's the best way to do this training? We've described what it is. It's 4 hours long. It covers 4 topics. What makes the most sense for your area? How would you like to do this? They were the ones who became so creative. They came up with multiple ideas and suggestions, and they know their templates, they know their schedules, they know how it works.
Yeah, then you're getting that pull instead of the push. Awesome. You guys just have an amazing practice there. We did have someone that would like an example of how TeamSTEPPS was used in that clinical setting. For example, how would you use CUS in the clinic?
Well, I just had an example about a month ago, and I thought it was terrific because the MA that was in the clinic felt that she could call me directly. So she has a site leader, she has a director of nursing, and she couldn't reach either of them. And we had implemented a new vaccine, and our MAs here do give our vaccines if they're unit dose. We don't have them making any calculations. And this particular vaccine had a diluent with it. And she did not feel comfortable and confident that she could give this vaccine and give it well. And so she cussed to the registered nurse that was in the clinic with her, and the registered nurse did the right things. Well, let's do it together. Let's mix this together. Let's go in the room. I'll be with you when you give it. And she still was not comfortable, and she felt very confident that she could call her boss. Well, her boss was on vacation, so she called her director, who was not available, and she called me. And so we talked through it together and talked through it with the RN. And after having the conversation and the RN reassuring that MA, I will be here to give it with you. We'll do it together multiple times until you're feeling confident.
Great example. Thanks. We've also...
You know, Birgitta, just one thing, that I think CUS is probably the most popular of all the tools. As people really sort of engage with TeamSTEPPS and understand it, that permission to speak up when you're concerned and when you think that there's a safety issue is so empowering. And I think that of all the tools that we've taught throughout our organization, that one has been embraced the most.
And that's exactly what she said to me. I have to call you because I need to cuss. It was really cute.
We told them in the training session, we're going to teach you how to cuss without getting fired.
Exactly. The other questions that is kind of bundling together are the challenges that you may have experienced with turnover and onboarding of new people. And is that something that the TAC handles, or how do you work with that?
So as TeamSTEPPS rolled through the system and we got all the current employees trained, then that was the question, how do we keep it going with new employees? So we developed a program which we fondly call HOTS, Hospital Orientation TeamSTEPPS. On the first 2 days, one of the first 2 days at the hospital, they go through a TeamSTEPPS session. Now granted, this isn't as tailored to a specific site or department, but it still gives them the general concepts and still do some exercises that will help solidify some of the tools.
Then when they go to their area, the TAC will sort of embrace them and give them some understanding of how TeamSTEPPS is used within their area.
At least sets them up with a common language.
Right. And that standardization is so important. So let's look at, you talked about sustainment. So what have been the benefits that you realized after implementation? How has that maybe affected the ratings on your patient safety culture surveys? Things like that. If you could just briefly, in the few moments we have left.
Sure. So, Birgitta, what we do when we're looking at an area for implementation of TeamSTEPPS, We go in with a version of AHRQ patient safety survey, and we gather information regarding their current sort of self-evaluation and how they view themselves in terms of patient safety, communication. We also ask about job satisfaction. And we then do a post-survey afterwards. And what we found is that those areas that have embraced TeamSTEPPS and formed a TeamSTEPPS Action Council have had improvements in all those areas. We also have our system-wide AHRQ survey. And our patient safety officer actually looked at that and found that those areas in the hospital that had completed TeamSTEPPS and implemented a TeamSTEPPS Action Council had higher scores than the areas that had not done TeamSTEPPS.
Great. All right. Well, we did have Amy wanted to know if you chose the 4 topics or were those part of the traditional curriculum?
Yeah, but it's part of the traditional curriculum. So what we focused on was leadership and team development, communication, situation monitoring, and mutual support. Now what we would modify is which tools we emphasize depending upon the area. So for some, CUS would be very important, SBAR might be very important, brief huddles and debriefs may be very important, and so we would sort of let the instructors guide us in terms of deciding which tools were going to be most important for their areas. We'd also use the AHRQ survey data.
Okay, great. A lot of always, shy away from inventing new things, right? And look at what we're already collecting and what's available. AHRQ certainly has a large amount of resources for that. Okay. Oh, and now just we talked about CUS, and McGrath mentioned that, yeah, they agree CUS is the favorite tool. However, DESK is the tool needed the most, and in their estimation, used the least. How was DESK received during your training, the DESK script?
I think it's well received, but I think that it's hard to implement based upon a very brief training. So what we're actually looking at right now is we're looking at developing a coaching system for TeamSTEPPS and having coaches work with each of the TACs, because I think tools like DESK really require a little more role play, opportunities to use the tool and get feedback before you're actually able to use it on an ongoing basis.
I agree. All right. I think that covers all of the questions that we've had. We have maybe a few more minutes if there's any other ones. Any other questions? And Michelle wants to know if you offer refresher courses.
So we found that was important. If a site that's implementing a TAC had gone through the training some time ago, that we needed to do that. And so with a master trainer assigned to the TAC, they would come in with the group and go through the principles again with them, just to refresh everybody on it. And that was incredibly helpful.
Okay. And now I found it beneficial if you're just doing it day in and day out, that large push for a standard refresher is not needed. It should build it into the culture, right? So you just have to talk about it constantly.
That's right.
And then Paula was asking if you have a standard improvement model, or lean, or does it matter?
So we have Lean Six Sigma here.
Yeah, Paula,
Lean
I did.
Helps with some of our projects, but we let the TAC decide how they want to measure their projects and the tools that they want to use.
Great. All right. Well, I want to thank everyone for their participation, the wonderful questions that you asked, and most importantly for MetroHealth for sharing their processes with us, their journey. It's just been a wild ride, hasn't it, for you guys? From starting with the inpatient, now moving the ambulatory. How exciting! How exciting! I just want to remind our participants that if there's any questions that come in that have not been answered, we will collect them all and forward them to the MetroHealth team, and then we will get their answers and email the questions and answers to you. So MetroHealth, I thank you and just wish you continued success along your journey.
Thank you.
Thank you.
Thank you for the opportunity.
Ladies and gentlemen, that concludes today's presentation. You may disconnect your phone lines, and thank you for joining us today.